Pandemics and epidemics have ravaged human societies throughout history. The plague, cholera, and smallpox killed tens of millions of people and destroyed civilizations. In the past 100 years, the Spanish flu of 1918 to 1919 and HIV/AIDS caused the deaths of nearly 100 million people. The 1918 influenza pandemic, starting from January 1918 to December 1920, colloquially known as Spanish flu, was an unusually deadly influenza pandemic, the first of two pandemics involving H1N1 virus. It infected 500 million people around the world, including people on remote Pacific islands and in the Arctic, and resulted in the deaths of 50 to 100 million, around 3 to 5% of the world's population then, making it one of the deadliest natural disasters in human history. Advances in medicine have transformed our defenses against the threat of infectious disease. Better hygiene, antibiotics, diagnostics, and vaccines have given us far more effective tools for preventing and responding to outbreaks. Yet, the severe acute respiratory syndromes, also known as SARS, the Middle East Respiratory Syndrome, known as MERS, and the recent West African Ebola outbreak showed that we cannot be complacent. Infectious disease outbreaks that turn into epidemics and potential pandemics can cause massive loss of life and huge economic disruption. Concerning the burden of infectious diseases, at the moment, around 2.5 billion disability-adjusted life years, also known as DALYs, caused by all diseases in 2013 worldwide. 520 million were attributable to infectious diseases. 4 infectious diseases were among the top 10 causes of disease burden globally. These are lower respiratory tract infections, diarrheal disease, HIV/AIDS, and malaria. The primary cause of infectious disease is loss of life. According to NOPAS, 5 infectious diseases, namely respiratory tract infection, HIV, diarrheal diseases, tuberculosis, and malaria, were among the top 10 global causes of death in 2001. Because onset is earlier in life than other top causes, such as ischemic heart disease, their impact is magnified when the outcome is not merely deaths, but loss of life years. Together, all infectious diseases account for more than 25% of premature death globally. A secondary impact of infectious disease is reduction in income and thus consumption. There is a large literature on the impact of disease and health generally on income. Although much of this literature studies infectious diseases, it does not identify any impacts on contagious disease that differ from impacts of non-contagious disease, and interactivity is treated as having little economic consequence. This is surprising, as one might suspect that infectious diseases may have important consequences for the location or disruption of economic activity. The literature on the role that individual incentives play in infectious disease dynamics and control can usually be sorted into 3 categories. The first includes papers that examine the impact of disease prevalence on self-protection and in return the effect of self-protection on prevalence. The main conclusion here is that self-protection both slows the spread of infections and reduces the return from public interventions to slow disease. The second category comprises papers that examine the demand for treatments and vaccines. These papers conclude that both treatment for the infected and vaccination to prevent infections have positive externalities on population prevalence. The challenge is how to solve this public goods problem, especially given that treatment or vaccination and other forms of self-protection are substitutes. The third set of papers examines the demand for information on one's infection state, that is, on testing. For diseases such as HIV/AIDS, testing is important because it is a prerequisite for treatment, and availability of treatment may reduce the cost of risky behavior. Initially, models and simulations of disease dynamics in the mathematical epidemiology literature assumed that individual risk-taking was exogenous. An increase in disease prevalence accelerated the spread of disease and thus its consequences. These models also suggested that interventions to reduce prevalence, either treatment for the infected or vaccination that prevented infections, actually has significant effects on prevalence. More sophisticated analysis introduced sensitivity analysis that examine the effects of interventions while varying the degree of risk-taking by individuals. Although risk-taking was still exogenous, it means it does not decrease because of prevalence. These analyses demonstrated that high levels of risk-taking could swamp the efficacy of treatments and vaccines. In the late 1980s and the early 1990s, the economic models preceded a formal demand for risky behavior, such as sex, and assumed that the cause of risky behavior included infections. Since disease prevalence increased in the chance of infection, it reduced demand for sex. The notion of prevalence response elasticity was born. The important implication was a feedback loop that slowed the spread of disease without any public health intervention. Growth in prevalence reduced risk-taking, which in turn reduced growth in prevalence. For infectious disease, both vaccines and treatments have positive externalities. By getting treated or vaccinated, one enters and expands the population of uninfected or resistant individuals. The larger this population, the lower the risk of infection for other individuals. Because individuals do not internalize this external benefit, however, there is a socially insufficient demand for treatment and vaccines, though in practice it is assumed the private benefit of treatment is sufficient to induce universal demand. The natural implication is that vaccination should be subsidized. The concept of prevalence response elasticity, however, complicates this conclusion. Because public health interventions reduce prevalences, they also reduce self-protections. As a result, public subsidies and self-protections are substitutes. Indeed, if vaccination is voluntary, not even subsidies will be able to achieve universal coverage. As the fraction of the population that gets vaccinated approaches 1, the demand for vaccination falls to 0 unless the subsidy is greater than the private cost of the vaccine. Even a mandatory vaccination program may fall short if it does not cover the entire population. The mandatory program will reduce demand among the exempt population. The third topic that has garner substantial attention in the literature on individual incentives is the demand for information on one's disease state. Information is important for two reasons. First, it may be a prerequisite for obtaining treatment. For example, one cannot get a script for an retroviral without a test result confirming that one is HIV positive. Second, aggregate data on prevalence may depend on voluntary testing. In this case, the data will report prevalence only among the population that chooses to test. Because information is costly, either because tests are costly or because there is a stigma to being sick. Demand for information is not universal. People will demand information only if they expect it may materially change their prior beliefs. Low-risk individuals who are fairly certain they are not infected will not demand testing, nor will high-risk individuals who are fairly certain they are, unless testing is necessary for treatment. It is mainly individuals who have priors around, say, 1/2 probability of infection who will test. Institutional incentives for control of infectious diseases operate in ways similar to those individual incentives, but with important contextual differences. Take the example of hospital incentives to control infectious disease outbreaks. Often, patients are colonized with disease-carrying bacteria in one healthcare institution and carry these to another institution. Investment in infection prevention at any single institution, therefore, benefits both that institution as well as others, which would have fewer incoming infected patients. Interestingly, incentives to control infections strongly depend on the number of incoming patients who are colonized with disease-causing bacteria. If the number increases, it would be in a hospital's interest to ramp up its infection control. However, if too many incoming patients are colonized, it would be hopeless for the hospital to try to control the epidemic on its own without cooperation of other institutions, and its optimal infection control expenditure should decline. At the level of countries, incentives related to infectious diseases operate on a similar principles. Control of malaria in South Africa, for instance, is possible if its neighbors, particularly Zimbabwe and Mozambique, were also willing to fight malaria within their borders. Returns to investment in control are diminished if a large number of patients carry these diseases across borders. Thus, a country's incentives to control a freely moving disease like malaria are determined as much by its ability to stop the inflow of infected individuals as by the ability to control the disease within its own borders. Reducing malaria in a country could have transboundary benefits by incentivizing infection control on its neighboring countries as well. This principle also applies more generally to the challenge of global disease eradication. The elimination of disease in all forms anywhere on the planet is a global public good, since it theoretically suggests that countries can seize all control measures and vaccination programs. Eradication is a binary public good. The maximum benefits are achieved when the disease is completely gone. However, incentives for the last country to eliminate the disease may be insufficient for two reasons. First, the benefits that accrue to the entire world when the last country achieves eradication are almost certainly much larger than the cost of eradication, as well as the benefits of eradication in that country are known. Second, the benefits in the last country may be small because the disease has been eliminated anywhere and there is no risk of importation. Diseases that have already been eliminated in high-income countries are the best candidates for eradication in the rest of the world. Indeed, it may be the financial interest of high-income countries to finance global eradication so that they can reduce their expenditures on prevention and control. In general, disease eradication, which requires simultaneous elimination in many countries, call for strong international institutions that can enforce a cooperative optimum, even when the Nash equilibrium is for no country to eliminate the disease. Given that inevitable constraint of limited treatment resources, there is not enough money to treat all infected individuals, even for a disease like HIV, with unprecedented resources made available for treatment. For instance, in Zambia, a country with one of the best funded malaria control programs in sub-Saharan Africa, only 13% of children with malaria receive effective treatment. Questions of optimal allocation of resources across different populations are not just of academic interest. International policymakers at the World Health Organization and the Global Fund for AIDS, TB and Malaria, as well as national ministries of health, are charged with allocating limited treatment resources across different populations that have different prevalence levels of infection. Although the stated objective of these agencies is to reduce the burden of disease, the focus is on populations with the highest burden of disease. The allocation of scarce financial resources for disease treatment between geographical regions is usually guided by disease burden. But this basis does not recognize the dynamic nature of infections. Treating a single infected individual not only cures that individual, but also prevents other healthy individuals who are in close proximity from getting infected. Northon addressed the question of optimal allocation of treatment resources across two connected populations when there is a period-by-period constraint on the number of treatments available to the social planner. Such a constraint is realistic and relevant from the perspectives of most health authorities, which are given annual budgets and cannot transfer funds intertemporally. The academics find that the optimal solution is to preferentially treat the population with low prevalence of infection before allocating remaining resources to the higher prevalence population. Whereas the usual policy is to provide a larger treatment budget for the more highly affected district. They find that, from an economic perspective, disease burden may be a poor criterion to use for allocating treatment resources. However, the paper by Northon relies on a simulation model and cannot conclusively prove that a corner solution is always optimal. This result is shown analytically in another paper written by Anderson in 2010. The intuition underlying this finding is that the economic value of treatment is greater in this population because of the lower probability of reinfection. From a methodological perspective, The proof depends on the concavity of the cause function. We showed that with just a single group, the minimized cause function in every period is weakly concave in the overall wealth allocation. Given this concavity, it is then straightforward to show that with two groups, the health authority will allocate all wealth to a single group. With the signing of the revised international health regulations in 2005, the international community agreed to improve the detection and reporting of potential public health emergencies worldwide. The revised international health regulation better address today's global health security concerns and are a critical part of protecting global health. The regulations require that all countries have the ability to detect, assess, report, and respond to public health events. The international health regulations are a framework that will help countries minimize the impact and spread of public health threats. As an international treaty, the international health regulations are largely legally binding. All countries must report events of international public health importance. Countries are using the international health regulation framework to prevent and control global health threats while keeping international travel and trade as open as possible. The international health regulations, which are coordinated by the World Health Organization, aims to keep the world informed about public health risks and events. The international health regulation requires that all countries have the ability to do the following. The first one is detect. Make sure surveillance systems and laboratories can detect potential threats. Second, assess. It means working together with other countries to make decisions in public health emergencies. Thirdly, report. Report specific diseases, plus any potential international public health emergencies through participation in a network of national focal points. Lastly, respond. Respond to public health events. The international health regulation also includes specific measures countries can take at ports, airports, and ground crossings to limit the spread of health risk to neighboring countries and to prevent unwarranted travel and trade restrictions. In today's interconnected society, it's more important than ever to make sure all countries are able to respond to and contain public health threats. In 2003, severe acute respiratory syndromes, SARS, threatened global health, showing us how easily an outbreak can spread. Recently, the Ebola epidemic in West Africa and outbreaks of MERS coronavirus have shown that we are only as safe as the most fragile state. All countries have a responsibility to one another to build healthcare systems that are strong and that work to identify and contain public health events before they spread. While previous regulations require countries to report incidents of cholera, plague, and yellow fever, the revised international health regulations are more flexible and future-oriented, requiring countries to consider the possible impact of all hazards, whether they occur naturally, accidentally, or intentionally. International health regulations cover all events that might potentially become a public health emergency of international concern. And global health security is not just a health issue. A crisis such as HIV or Ebola can devastate economies and keep countries from developing. the World Bank Group estimates that Guinea, Liberia, and Sierra Leone together will lose at least 1.6 billion US dollar in foregone economic growth in 2015 as a result of the Ebola epidemic. The impact of this kind of economic devastation reaches further and wider than ever. The ideas behind the international health regulation are not new. We have known for a very long time that what affects one country can affect other parts of the world. This is especially true today, when we are so closely connected to everyone else. And global health security is not just a health issue. A crisis such as HIV or Ebola can devastate economies and stall future development. And the impact of this devastation reaches further and wider than ever. As the world broadens, our responsibility to reach other broadens along with it. Before the outbreak of SARS in 2003, previous international agreements had been designed to address specific diseases and public health situations. However, the SARS outbreak made the world aware that we now face threats that might not be foreseeable, from newly emerging diseases to chemical or radiological hazards to bioterrorism. After SARS, the international health regulations were revised to address these modern threats and to cover all events potentially constituting a public health emergency of international concern. While the previous version of the regulation required countries only to report incidents of cholera, plague, and yellow fever, the revised IHR remain more flexible and future-oriented, requiring countries to consider the possible impact of all hazards, whether they occur naturally, accidentally, or internationally. The international health regulation represents obligation for almost 200 WHO member states to work together for global health security. The regulations require that all countries have the ability to detect, assess, report, and respond to public health events. As part of their commitment to the international health regulation, participating countries agreed to comply with these rules by 2012. However, by 2012, fewer than 20% of countries had met the international health regulation goals. By 2014, only around one-third of participating countries reported fully achieving the core capacities. The Emergency Committee is made up of international experts who provide technical advice to the WHO Director General in the context of public health emergencies of international concern. The committee provides views on whether the event constitutes a public health emergency of international concern, the temporary recommendation that should be taken by the country experiencing an emergency of international concern, or by other countries to prevent or reduce the international spread of disease and avoid unnecessary interference with international trade and travel, and the termination of public health emergencies with international concern. The Director General makes the final determination of public health emergency of international concern and temporary recommendation to address the situation, based on advice from the Emergency Committee. Information provided by the states parties, scientific experts, and an assessment of risk to human health, risk of international spread of disease, and of risk of interference with international travel. Under the International Health Regulation, temporary recommendations automatically expires 3 months after their issuance. Emergency committees are therefore reconvenes at least every 3 months to review the current epidemiological situation and to review whether the event continues to be a public health emergency of international concern and whether changes need to be made to the temporary recommendations. A statement of the International Emergency Committee meeting is published on the WHO website after each meeting of the committee. Potential for economic modeling to guide preparedness efforts against pandemic influenza, as it can provide information that can be useful when planning for rationing, shortages, and prioritization of intervention during an epidemic. Models that provide information about mortality from pandemics and the effects of vaccine. It is difficult to make precise mortality estimates about future pandemics, even with good economic and epidemiologic models, he said. Death rates estimates are in the form of a range of potential outcomes depending on gross clinical attack rates, which are not a precise prediction. Economic models can help evaluate the cost effectiveness of vaccination programs by age group and risk, including comorbid conditions and pregnancy. Economic analysis of vaccination has produced positive rates of return for every age and risk group, but at varying magnitude. Categorizing people into age and risk groups can help determine who to vaccinate first in the case of a supply shortage. Population groups can be evaluated either by their risk of death or by their potential future returns to society, the latter of which would favor vaccinating working-age people before the elderly. Scientists noted that determining the best approach to this type of valuation is beyond an economic problem and is up for debate for society. He added that the best way to carry out an economic analysis from his experience is by using simple models that are transparent, take account of uncertainty about the severity and the size of impact of the pandemic, and are readily accessible to the public. Law can contribute to the prevention of infectious diseases by improving access to vaccinations and contraceptives, and by facilitating screening, counseling, and education of those at risk of infection. Law also has a reactive role, supporting access to treatment and authorizing public health authorities to limit contact with infectious individuals and to exercise emergency powers in response to disease outbreaks. Where public health laws authorize interferences with freedom of movement, the right to control one's health and body, privacy, and property rights should balance these private rights with the public health interests in an ethical and transparent way. Public health powers should be based on the principles of public health necessity, reasonable and effective means, proportionality, distributive justice, and transparency. Immunization is a successful and cost-effective public health strategy that saves millions of lives each year. Governments can support vaccination coverage by ensuring that vaccination is free or affordable, by ensuring that all children are vaccinated, with limited exceptions for medical or religious reasons, and that vaccinations are documented. Screening individuals to determine if they have been infected with or exposed to an infectious disease is a core public health strategy. Early treatment has important public health benefits. For example, people receiving treatment for tuberculosis and HIV infection are less likely to transmit the infection to others. Routine voluntary HIV testing benefits both affected individuals and their intimate partners by facilitating early access to prevention, care, and treatment services. Health laws can improve the success of voluntary screening programs by including counseling requirements, ensuring the confidentiality of test results, and protecting individuals diagnosed with particular disease from discrimination. Public health laws should protect the confidentiality of a person's HIV status, authorizing disclosure to third parties only in limited circumstances where a third party is at significant risk of HIV transmission and where other statutory preconditions are met. Government should carefully consider the appropriate role of criminal law when amending laws to prevent the transmission of infectious and communicable diseases. For example, criminal penalties for transmission of HIV may create disincentives to individuals to come forward for HIV testing and treatment, or may provide the pretext for harassment and violence against vulnerable groups. Encouraging personal responsibility and self-protection is critical, especially in countries where rates of HIV infection are high. Public health laws should authorize compulsory treatment only in circumstances where an individual is unable or unwilling to consent to treatment, and where their behavior creates a significant risk of transmission of a serious disease. Compulsory treatment orders should restrain individual liberty only to the extent necessary to most effectively reduce risk to public health. There is concern among public health professionals that the current economic downturn initiated by the financial crisis that started in 2008 could precipitate the transmission of infectious diseases while also limiting capacity for control. Although studies have revealed the potential effects of economic downturns on overall health, to our knowledge, such an analysis has yet to be focusing on infectious diseases. We perform a systematic literature review of studies examining changes in infectious disease burden subsequent to periods of crisis. The review identified 230 studies, of which 37 met our inclusion criteria. Of these, 30 find evidence of worse infectious disease outcomes during recession, often resulting from higher rates of infectious contact under poorer living circumstances, worsened access to therapy, or poorer retention in treatment. The remaining studies find either reductions in infectious disease or no significant effect. Using the paradigm of the susceptible infected recover SIR model of infectious disease transmission, we examine the implications of these findings for infectious disease transmission and control. Key susceptible groups include infants and the elderly. We identify certain high-risk groups, including migrants, homeless persons, and prison populations, as particularly vulnerable conduits of epidemics during situations of economic duress. We also observe that the long-term impacts of crisis on infectious disease are not inevitable. Considerable evidence suggests that the magnitude of effect depends critically on budgetary responses by governments. Like other emergencies and natural disasters, preparedness for financial crisis should include consideration of consequences for communicable disease control.